Yeah, it's now recorded.
Okay. Hello.
Hi, Hajia.
Hi.
Yeah, I think it is now
Yeah.
recorded. Yes, done it.
It's now
Yes.
recorded.
Okay, so I'm talking about, let me quickly go over it. I'm saying that physiology of first stage of labor. When the placenta, when the baby is out, placenta cannot be compressed, and so it starts separating from the uterine wall. The placenta side becomes smaller, and so placenta will definitely have to be separated. And now when it starts separating, I said that once it starts separating, I said, look at my part as the fundus of the uterus, and then that is the placenta. So you see something like this. Then placenta will start from separating from the center, and that is what we call the Schultz method of placenta separation. When it starts separating like that, I said the blood from the intervenous space of the placenta will then shunt back to fill the maternal blood vessels. And I use my fingers as the open sinusoid of the maternal surface of the placenta. So what happens is that I said I use this as the oblique muscle fibers. Then it will entangle the maternal blood vessels. It will tighten it up. It will tighten the maternal blood vessels this way. That is what the oblique muscle fibers do. Now, when it does this, when the maternal blood vessels are tightened up like this, I said blood from this intervenous space of the placenta will shunt back to fill the open vessel, to fill this one, in an attempt to go into the maternal circulation. But the oblique muscle fiber, because of the way it has ligated the vessels, the blood cannot go into the maternal vessel. So the blood can only fill up at these surfaces, at the tip or the surfaces of the blood vessels. It will fill up and then make it engorge, because there's no chance for it to fill the maternal vessels backwards. Then these vessels, open sinuses here, will then rupture. It will burst. Once it ruptures, then the blood will then shunt back onto the placenta surface, onto the maternal surface of the placenta, this side, to form what we call the uteroplacental clots. It will form the uteroplacental clots. And I said this clot is going to compress, it will weigh the placenta down and separate more placentae. It will then, the weight of the clot will separate more placentae and then pull it down, weigh it down. So as the placenta comes out, because it goes separated by a method called Schultz method, SCHULTZ, Schultz method. Because it's separated by Schultz method, you see that the delivery field will not be messed up. It will not be messy with blood. But then the clot will be kept inside the placenta and then it will be delivered. Whereas if the placenta starts separating, the clot door will form, but the placenta will separate from the edge. It will separate from the edge. So it will behave like you are removing a button from a hole. It will turn like this. So you see that in the delivery field, the placenta clot is here. So the clot sometimes will come out first. And that one is what we call Matthew Duncan's method. Some books are calling it dirty Duncan's method. Dirty because the clots and the blood will mess up the delivery field, making the place messy. It will mess up the place. It will make it dirty. Hence the name dirty Duncan's method of placenta separation. It's a physiological change. It's a physiological change that will bring about. Then after that, after the placenta has been separated, what happens is that the uterus will now go into contraction. So,
Hajia,
yes.
please, can you go over the second method, please?
The second method, I said it is called the Matthew Duncan's method. I said when the uteroplacental clot shunt back to the maternal surface. And because the placenta will start separating from the edge, like a button that is coming out of a hole, you see that the maternal surface will be delivered first. Look at it. The maternal surface will be delivered first, meaning that the clot that was formed here will even come out first before the entire placenta also follows, making the delivery field messy. It will make it dirty. That's why some people call it dirty Duncan's method. So you see the maternal surface first at the vulva before the entire placenta follows. Whereas in the Shields method, the fetal surface will be seen first, and the uteroplacenta will be kept inside the membranes. And so the delivery field is not dirty. That is what I'm saying. Yes.
Yeah. So when you were explaining the Shields method, you said when the baby comes out, and then the placenta, because it is you can't compress it, it will also come out, making the cavity small. And when it tries separating from the edge of the endometrium, there will be black clot formation. That is trying to fill the sinuses of the maternal surface.
Good.
So now this force, when it bursts, will push the placenta out, and then later the clot will come. So with the maternal surface, the Duncan method, now that it is starting from the edge, what is causing the black clot to compress and push the placenta out? Because now it is the edge that is coming out.
It is the egg that is coming out. So the placenta, the clot is there. It will push it, but then once you make an attempt to deliver the placenta, you see that the clot will be seen first. Once the weight of the clot is on the placenta, it will force it to separate. Even though it is separating from the edge, it will still separate it.
So meaning that it will reverse. The maternal edge will follow, then the placenta will go back and then come again. Is that what will happen?
Oh, the placenta will not go back. It will go back to where?
Like I'm saying, like now that the edge is coming, the retroplacenta is now taking the lead of the thing. So before, with the Shields method, the placenta was pushed forward.
Yes.
By this one, it is the edge that is now coming. So the placenta now occupy the space of the retroplacenta, and then the retroplacenta will take the lead. Is that it?
That is exactly what I'm saying. That is exactly what I'm saying. But remember that even though the retroplacenta is taking the lead, it will still exert pressure on the placenta to get separated and come out. Are you getting it? Hello?
Yes.
Okay. Okay. So that is all about the physiology. Let's quickly deliver the placenta. Please, the placenta, after during the third stage of labor, as soon as the baby is delivered, the midwife does abdominal examination to ensure that there is no retained baby. There is no undiagnosed twin. Before you give the embolic drug, every facility and the type of drug that they use to control bleeding. Some give egometrin, 0.5 milligram, as soon as the baby is delivered, before the placenta. Some give pitocin, some give oxytocin, some give symptometrin. So it depends on the protocol of the hospital. But remember to ensure that there's no fetus left in utero. Sometimes the diagnosis was not rightly made by an ultrasound. There was multiple pregnancy, but the interpretation said that it was a singleton fetus. And so you, the midwife, will have to palpate to ensure that there's no retained fetus before you give the uterotonic drug. Now, after giving the drug, please don't wait for all the signs of placenta separation. Don't wait for all the signs. And what are the signs of placenta separation? What are the signs of placenta separation? Theophilia, Zaleligu, Rebecca. Why is it that when we mention your name, then you'll be running away? Stereocampion.
Lengthening of the cord.
Lengthening of the cord,
Gushing of blood.
Gushing of blood from the placenta side to indicate that it has separated. Gushing of blood, good. What else? The most important thing you haven't mentioned.
Yeah.
You can see the perineum on VP.
The fundus
You do
becomes
V.
rounder.
You don't
Try
do V.
contraction.
It's
Contractions.
at the perineum.
The mother will
You do V to confess whether you can see the
Visible, this thing, placenta and the vagina.
Please, you don't do V. Don't do V. Please, we are managing third stage
the
of labor.
placenta will be seen in the
In
vulva.
the
The
vagina.
placenta will be seen at the vulva. The placenta will be seen
Check
at
for
the vulva.
contracted uterus.
The uterus
Sister,
will be
how am I going
contracted.
to see the placenta in the vulva?
Yes, good. So somebody mentioned that you do V. Please don't do V. Those of you who are fond of doing V, don't do V. So please remember that as soon as the baby comes out, mother might have passed physics. Clear the field. Remove the items. Remove those items. Remove the toilet and then the toilet paper, the balls and all those. Remove it and then make the woman comfortable. Before you change the glass to conduct the third stage of labor, and you should speed up. You should speed up to do all this procedure. Now, after that, I say change your glass. When we are going to manage third stage of labor, change your glass. Wear a new examination glass. Now,
Yes, sister.
yes, then you try to use your left hand to feel for uterine contraction. But we are saying that once you are giving the uterotonic drug, don't wait for all the signs of placenta separation before you make an attempt to deliver the placenta. Please take this point very, very serious. Once you have given any embolic drug, don't wait for all the signs of placenta separation before attempting to deliver the placenta. Otherwise, the placenta will get trapped. But with the first uterine contraction, once you give the drug, feel for the first uterine contraction on the fundus. The uterus will feel like a tennis ball. It becomes mobile. Then it tells you placenta has separated. If you wait for all the signs that we have mentioned, the placenta is likely to be trapped. So then, once you feel for the first uterine contraction, support the uterus or the fundus with your left palm. Support the fundus with the left palm to prevent uterine inversion. You don't want the uterus to invert. And so you are supporting the fundus to prevent that one. Then you get hold of this is the cord, this is the placenta. You can wind the cord around your fingers like this because of the slippery nature of the cord from the amniotic fluid. Let me put Jendari somewhere so that I can feel comfortable to go on with my description. So I'm saying that there are two ways of removing the placenta. You can clamp the cord closer to the vulva, but please make sure you don't clip the woman's clitoris in addition to the clamping of the cord. Be very careful. Other than that, the patient will shout and everybody around will come and see what you are doing to the woman. So there are two methods. You can use the forceps, clamp it this way, and then you hold onto the forceps and deliver the placenta. Or you can still, to avoid that clamping and causing mess, you can wind the cord around your fingers to avoid that slippery nature. Now you support the fundus, then you deliver the placenta. Now, in the process of delivering the placenta, delivering the placenta, please watch out. As you deliver the placenta, if it is coming by the Shoes method, you see something like this. You see the fetal surface coming first. Then you support the fundus, and then you deliver the placenta. Once you see the fetal surface this way, leave the fundus, please, leave the fundus, and then receive the placenta into your palms. Receive the placenta with both palms. Now, as the placenta is received, you try to twist it. Please watch out. You twist the placenta. You say, I'm twisting the placenta to leave the cord. You twist the placenta. By twisting the placenta, you see that the membranes will form something like a rope. The membranes will all gather so that you are not likely to get a torn membrane left in utero. Please, I hope you are getting it. Just twist the placenta. You twist it this way, twist it that way, and then the membranes will form something like a rope. It will gather itself, and then you tease it out gently. Just be gentle with the membranes, because the slightest amount of membrane that is left in utero is enough to cause postpartum hemorrhage. So tease the placenta out gently the membranes out gently by moving the membranes up and down, up and down. If it is about to tear, you can feel it. So you can then take the forces and clamp the torn membrane. Move it up and down gently, and then tease it out from the vagina. As soon as the membranes are delivered, have a quick look at the placenta for any missing lobe. If there's a missing lobe, when you bring it together, you will see something like this. Please, I'm taking the lobe out. Please, have you seen? You bring it together, and you can still see a hole inside the placenta. Please, can you see the hole? You see? You can still see there's a missing lobe. Yes, there's a missing lobe. Then if there's a missing lobe, you have to make sure that you get rid of that lobe. By doing what? By massaging the fundus. When you finish, massage the fundus. So sometimes you may be asked, what is the best action? What is the best action of the midwife immediately after the delivery of the placenta? The best action is to massage the uterus to contract.
Yeah, inside. We have to do and take it.
So you see that the best action the midwife does after delivery of the placenta is to massage the uterus to contract. You massage it to contract, and then you expel the product. Then you expel the product.
What's the name? Yeah, getting this thing. Getting this thing up there.
Go and sit in the waiting room and make that noise. Okay, so then what happens is that you massage the uterus to expel the product. Because when you massage it and it's not well contracted, and you make an attempt to expel the fundus, we call what we call indentation. You are likely to cause uterine inversion. So anytime you massage the uterus to contract, feel the contraction before you attempt to expel the contents. That one, you can't cause any uterine inversion, because uterine inversion is one of the obstetric emergencies. It's an obstetric emergency that needs to be repaired or pushed back. It's very important. So don't expel any fundus that is not contracted to avoid uterine infection. Okay. Now, after that, I said, have a quick look at the placenta. You just want to ensure that it is complete. But the proper examination is going to be done in the sluice room. So you put it. Go and sit in the sitting room there and make that noise. So at the end of the day, you see that the uterus should be massaged, and then have a quick look at the placenta, put it in the receiver. You are now going to examine it proper in the sluice room. Now, after this process, the next thing that the midwife does is to examine the birth canal. which most of us refuse to do. You do that and you cause havoc in the life of the mother. So what you need to do is you are going to examine the birth canal. You have to use 2 pieces of gauze. Wrap it around your fingers like this. Please look at me. This is my piece of gauze. You wrap it around your fingers. Please, have you seen it like this? You do same to the other finger. You do same to the other fingers like this. So you wrap your fingers with the gauze. Position the woman, tell her, explain the procedure to her, because now a baby has passed through the vagina, there are bruises, and she's in pain. You are coming to enter her vagina without telling her. She won't cooperate well with you. So you tell her, Madam, I'm coming to inspect your vagina to see if there's any tear. Then I'll suture it for you so that you attain the same size of vagina that you used to have, so that you get that same thing. Now, so what you do is you enter, please watch. You enter, you open up.
This one, waiting room straight.
I'll send them there. Don't worry. I'll send them there. They should make the noise super there. This is what they've been doing, and when it reaches labor, chipping in is for you people to be careful and be cautious of when it comes to labor. This is what they've been doing, and could you believe that people are being referred in labor? This is what they are doing because they are not paying attention. And they don't study the labor because they think that is what they are doing. That is my friend. Oh, the labor of what they are, what do you call it? Pharmacology or one labor. They will do that and it affects them in the end of semester exams. Yesterday, some people didn't allow me to sleep. Okay, I've been referred to labor. I've been referred in. I said, what happened? They don't take it serious. I'm sorry. So you inspect the birth canal for the clients by moving. First, you go this way, you express it this way, and a good lighting system. If there's any cut, you will see. Then you come down. You come down, press up, press down. Then you are viewing a service and a good lighting system. You can tell the client, Madam, push a little bit. She pushes a little bit, and you can view the service clearly. So that if there's any cervical tear, you can suture it. If there's any laceration at the vaginal wall, you can suture it. Don't leave it there. Patient probably was even already anemic. And so if there's a tear and you don't suture it, patient is going to bleed the more. Any question? When you finish, then you try to clean the patient, make her comfortable. Before you apply the perineal pad, ensure that you have folded the perineal pad. Please, let's assume this is my perineal pad. This is the size of the perineal pad. I'm going to place it at the patient vulva. What I'll do is I'll fold it. Fold it and place it at the vulva. Then turn the patient onto her side. She's lying in lycor. Clean the back, clean the buttocks. Then you turn her to the opposite side. Clean her nicely before you open the pad. Sorry. No, they should get inside the visit. The waiting room and share that thing that they are sharing. Okay. So that is how to manage the third stage of labor. Please, any question? make patient comfortable. Then you go to Sulu's room, examine your placenta, document your findings, give a feedback. Please, it is when after the delivery of the placenta that you have to show the sex to the mother. Please take note of it. Some people, as soon as the baby comes out, they are showing the sex to the mother to identify, mommy, oh, then the one will say, Oba or Bema. But please, we have realized that sometimes if the woman is not very happy with the sex that she has gotten, it can end up with severe postpartum hemorrhage. So we are saying, why don't you deliver the placenta first? Clean her up and they show her the sex of her child. So that whether she likes it or not, nothing can spark off the bleeding for her. That is it. Any question, please? Any question, please? You don't have any question to ask?
Hello, sister.
Yes, madam. Yes, madam, go ahead.
You are delivering the placenta. Where will you place the baby? Because you said we should
You said what? You said when you are delivering the placenta, where you place the baby? Oh, I didn't hear her well. You also heard her, can you tell me? He said, I think her line is breaking.
Yes, she said that.
Okay. So the baby was on the abdomen. You delivered the baby onto the abdomen for the first contact. When you cut the cord and place the baby on the mother's abdomen again for skin to skin contact, because we have now wiped the liquor from the baby. So baby can now be comfortably placed on the mother's abdomen. Then you ask the mother to hold her own baby. Sometimes the primigravida, for the first time the baby is coming in contact with her body, she's afraid. She's afraid. So you have to inform her before you place the mother on the abdomen. But then when you come to deliver the placenta, let the mother, you have already done your abdominal examination. There's no retained twin. And so you can ask the mother to support the baby on her chest. Once you operate at the lower abdomen, you support the family. There's nothing wrong with that one. If you think the mother is not capable of holding her baby, put the baby in the cot. Place her beside the mother. That one is also accepted. That is it. I think I've answered your question. Any question? Yes, Gloria, I can do.
Madam, please, my question is that after the delivery of the placenta, you said we should wrap some gauze around our 2 fingers and go in and inspect. So where does the going in with the sponge holding forceps come in? Or we shouldn't go in with sponge holding forceps again to clean the remaining blood? Okay.
You are inspecting. What I said, you should wrap your fingers with the gauzes. You are going to inspect the birth canal. But with but with the sponge holding forceps alone, you cannot be able to palpate or open up the birth canal. So you bring in the sponge holding forceps. When you ask the woman to push a little bit, then you clean the cervix. You clean around the cervix to see if there's any cervical tear. That is the only time that the sponge holding forceps with the gauze will come in. Now that your fingers that you have wrapped will pat the vagina sideways, will pat it up and down, and then you feel the birth canal. Have I answered your question?
Yes, madam. Thank you very much.
You are welcome. So that is it. Yes.
Please, after delivering the placenta, some midwives use their hands inside and try to scoop. Is it allowed?
No, it's not the best practice. It is not any best practice that a midwife should adopt. Don't enter the vagina again to scoop. If you enter, after a while, you asking the woman to ovulate early enough. The ovulation, when the woman gets up, whatever drainage that is there will come out. Even the scooping of blood that we are interested in scooping, what are the rest of the days? Because the bleeding is not going to stop overnight. It's not going to stop the following day. What about the rest of the blood that is inside? Will you be scooping every day? Come on, every day, madam, come and lie down, coming to scoop blood from your vagina. Then you put your hand there. The next day, madam, I'm coming to scoop blood. No. That's why we encourage them to do early ambulation. She gets up early enough, and then any lochia, any clot, anything that is left there. But the most important thing, we are saying that massage the uterus to contract and express the fundus. So those of us who have been putting our hands inside the vagina, we are only doing so to introduce infection. Let's not do that. Because anything that is left there, if you think the membranes has even torn, there's a retained membrane. Please put the woman on a gometrine. Put her on a gometrine if she's not a hypertensive patient. But even scholars are saying that even if she's a hypertensive patient, give her a gometrine to arrest the bleeding, because the bleeding will kill her faster than the BP that we think it is up. So that is it. Any question, please?
Yes, Hajia.
Yes, madam.
Hajia, please.
Please, I don't know if I heard or did not hear we taking you through the third stage of labor.
Taking what? Oh, please, whoever heard her can repeat it for me. I didn't hear it.
Passing a catheter to remove urine.
To drain urine. During the
after delivery of the placenta.
After the delivery of placenta.
Yes, before placenta.
Okay. So I'm saying that the catheterization is also another way of introducing infection. If somebody asks a question, let me answer her. Catheterization is also another medium of introduction of infection. So if patient is not bleeding, why do you have to pass catheter? Because you encourage her to empty her bladder frequently during the first stage of labor. And if prior to second stage of labor, probably you pass the catheter. Why do you make it a routine of passing catheter during the stage of labor? Once patient is not bleeding, please let's try not to do that, because the introduction of the catheter alone. Okay.
If there is a tear and you suture, can you pass the catheter to?
Yes. The catheter is in the urethra. And then I don't see why, if you have done suturing of perineum, you can't pass catheter. No, you can pass catheter. You can pass catheter.
Okay, thank you.
Okay.
Hajia, please.
Hello, sister.
Please, he said we are not supposed to scoop the uterus after delivering the placenta.
Yes.
Please, what if you suspect there is a retained product or something, and after massaging the uterus, it didn't even come out?
After massaging, if you massage it well and it is well contracted, there's no way that you express the fundus and that clot that has remained there won't come. It will come. So please, the hands that we have been introducing into people's vagina to scoop this thing, I say stop, please. It's not good. It's not good midwifery practice.
And sometimes you see some placenta tissues inside. So if you don't bring them out,
then that's why I'm saying that then it means you are going to bring them out every day. Every day you put your hammer, maybe that one I'm from essential, you could PM with your number. You do it every day. But is it right?
Hajia, please, I have a question.
Ask me, sister.
Okay, after the placenta has been delivered, the maternal cyanosis, is it a possibility that there can be bleeding from the cyanosis? And what is the difference between the blood that will ooze from the maternal cyanosis and the cervical tear bleeding?
What is, you say what is the difference? Did you say?
Sister, please, I said, I said, when the placenta is fully delivered out, is it a possibility that the maternal cyanosis can bleed again? And if it will bleed, what is the difference in color of that bleeding from the cervical tear bleeding?
Oh, cervical tear, you will see this fresh blood, bright red. It is coming from the cervix. There is a torn vessel inside the cervix that is bleeding. You are giving all the treatment, you are giving all those things. Please, I will treat postpartum hemorrhage with you, so I will dwell much on those points. But I'm saying that the difference is not that much. In placenta bleeding coming from the uterus, it is different from bleeding coming from the cervix. We call something traumatic PPH, and then we call something atony, PPH due to atony of the uterus. They are different, and the color of the blood will tell you whether it is trauma from the cervix or it is coming from the placenta side. You can clearly see this. I'll take you through the postpartum hemorrhage, and then you get the differences so clear. Is that okay?
Okay, please, Hajia.
Okay,
You also said that after delivery of the placenta, we are supposed to squeeze the surfaces together, like hold them in our hands and say, what kind of please. I had a network problem. Like, I want to know the rationale behind that.
Which one did I say you should bring together?
And after the delivery
like
of
when you deliver the placenta, no one
you have
baby
them together to set the completeness of the
grabs
placenta.
the maternal surface together. Like, I saw you pressing the edges.
She said we are supposed to twist it so that all the membranes will be brought together.
Yes, after that she has a cut or so bizarre.
There will be.
I need to look and be detected.
I said physiologically the uterus will come together in a position. The uterine wall will come together to compress on itself. It's one of the physiological changes during third stage of labor. For the uterus itself to arrest hemorrhage, the uterine wall itself is coming together. We call it acquisition. It will come together and compress itself like this to arrest hemorrhage. It is not you, the midwife, who is going to compress the uterus to. You are there to massage and express the fundus. But the position and coming together is a physiological thing that the uterus does it by itself. All these things are under the management of PPH, so we'll come to that one. Please, is there any more question? Yes.
Sister, please, I have a question.
Ask me.
Yes, please, you said we learned that we should wait to deliver the placenta before we show the sex to the mother. What about if the baby is asphyxiated and you want to send the baby to resuscitation place?
When the baby didn't cry, the mother will know that the baby didn't cry. She will know. She knows that the baby didn't cry. But it is not the sex that we are going to tell her. It's the fact that your baby is not, the baby's condition is not very fine. We are sending the baby to the resuscitation. You see, it didn't cry. Then you send the baby to the resuscitation. Go and resuscitate the baby. You have to inform the mother.
Please, at times they will say that you have first changed the baby. Maybe if the person is in particular of a particular sex of the baby.
She said you have exchanged the baby.
Yes, please.
For what?
Most people do that.
Oh.
I see, because of our settings, there is nothing like privacy. You'll be in one ward and you have like 5 women that are delivered. Maybe she took the scan and the first scan said female, and she is expecting a female, but she delivered a male. And this situation, it didn't show her the sex, but baby is asphyxiated. She will now come back and say, Miss Scan didn't say I'm giving birth to a male. So that is why we mostly show them the sex that we take any procedure.
I see. Okay. So if she didn't get the sex that she wants, do you think it has its own consequences? No, I'm asking you. Does it have its own consequence? If you
Yes, some people can sue you for that. They can sue you that she was told that you give birth to a female. Why are you saying the baby is a male? Because she saw there are other babies there. Maybe probably she's thinking you have exchanged her baby for another baby.
So you think showing her the sex or okay? I'm asking you.
Sister.
Yes.
Yes, sister.
Okay, so a lady asked the question about the bringing the placenta together after delivering of the placenta. She was asking for the rationale
behind bringing.
Yeah, that's what I mean.
I've gotten your point. I said bring it together like this, in your palm like this.
Yeah.
So that when I brought this thing out, I said if there's a torn member, we want to see if the lobes are complete. The rationale is to ensure that there's no torn membrane, what do you call it? Cotyledon, the lobe. All the lobes are intact. That's why you are bringing it together. If you bring it together like this, look at this one. Can you see? You bring it together and it is complete. You see that there's no hole inside. But if you bring it together like this and there's a missing lobe, please, can you see? You see there's a missing lobe. If I bring it together and there's a torn lobe, there's a missing lobe here, then I know that the lobe has retained in utero. So I have to keep on massaging the uterus and making sure it is well contracted and then express it. If it doesn't come, you realize that there's nothing coming. That is where you have to put the woman on ergometry to ensure that the uterus is contracted and this clot should come out. Other than that, you will end up with secondary PPH. If this clot, I say clot, lobe, if this lobe is retained in utero, it's likely to end up, or they'll bring her back with secondary postpartum hemorrhage. Now I do understand her.
Okay, so please, how do you examine the membranes to know that it is complete? The membranes.
Oh, the membrane, when you hold a cord like this, we haven't done examination of the placenta. We haven't examined the placenta. So let's quickly examine and then we can bring it. So please, do you have a question on the delivery of the placenta before we go on to the examination?
Yes, Hajia.
Okay, ask me.
Yes, Hajia, please. I want some clarification on the in NMTC. I was taught that when you are delivering the placenta, you embrace the uterus. I heard you saying that you support the fundus when you are delivering the placenta. So I don't know.
It's the same thing. Embracing the uterus
is the same.
Control contraction is the same thing, madam. Embracing the fundus,
okay,
supporting the fundus, you are preventing uterine invasion. It's the same thing. You can, it's the same thing. Either you embrace it or you support the fundus. The essence is you don't want the uterus to invade, especially if the placenta is not fully separated. You try to deliver the placenta, you pull it, and then it will bring along the inner side of the uterus. You have caused uterine invasion, and I told you it is one of the obstetric emergencies. So you don't want that.
Thank you very much.
Yeah. Okay.
Hajia.
Yes, madam.
I wanted to ask, when we were discussing about the cleaning of the vagina, you see, most of the time we midwives have a certain culture, and I want you to correct us. We mostly put the pad inside the vagina and attempt to clean the vagina. Sometimes we leave it inside for a little while before bringing it out. And I want to know if it is a good practice or it is wrong to do that.
Okay.
Most of the time when you do that, it comes out with a clot, a lot of clots, before we put the perineal pad to cover the perineum. And I want to know if we are doing the right thing.
No, please, that kind of practice, I don't know which books are talking about it. I've heard it, I've seen it. But which of the theorists or which of the artists is talking about after delivery, pack the vagina with this thing? Unless you can only do that unless you are suturing a perineum. If you are suturing the perineum, then even that one halfway you pack it because you don't want blood to occlude the suturing area. That's why you are packing it. But even it should be halfway of the perineal pad inside the vagina. Other than that, remember, as soon as the baby comes out and the placenta is delivered, involution of the vagina has started. Involution has started. And so for you to pack and compress and push it back, sometimes you push it and there's some of people even push all inside. The primary gravida is afraid even to enter the vagina. And it remains there and cause sepsis. It will remain there and cause sepsis. The patient becomes so offensive. She's feverish. So I keep saying that any patient, any pregnant woman that we bring to your facility with fever during the period, the first thing that we have to do, especially when it's offensive, the first thing, do vaginal examination. Check, they might have left a gauze or perineal pad inside her, and it's getting rotten. And she's in the state of getting sepsis. Every time, please take it from me, every time that a woman is brought, a pregnant woman with fever, rigor, think about retained perineal pad inside the vagina first, before even you think about malaria. Check her vagina, check it to see the sort of perineal pad that you see, it has become so greenish. Those of you who have experienced it before, please share your experiences with us. Share your experiences with us.
Okay, so Hajia, I've experienced it before. So I had this preemie gravida. We did I did suturing for her, a perineal suturing. So I kept a pad there for her, and then I asked her that immediately she goes to the bedside, she should urinate. So you see, most of the time you are also concentrating on other labor cases. So sometimes your mind doesn't come back on them unless there is bleeding or something. So this lady went and then called me on phone. I mostly give my number to them so that if they have issues, they call me. She called me on phone, one dawn, to tell me she was trying to urinate and she saw something at her vulva. I said, what did you see? So I even got worried. I thought that it was a suturing that was prolapsed or it didn't work well or something. But I told her she should come back to the facility. And then I don't know, when she said it, I said, oh, she should lie down and then I'll do a vaginal examination. I put on my surgical glove only to find out that the pad was still inside the vagina and it was even changing color. It had changed color. So I pulled it out and then I told her that I told you to take this thing out, and she said she was afraid. She was afraid of it. So she didn't know how to bring it out. So yeah, we have experienced it.
Thank you very much for sharing this experience. This is what we call academic honesty. That is what we call the lady, because she couldn't get chance to make noise today. I've told you that is her habit. She will come with the husband and start making noise. I'll put the two of them in the waiting room. You should go there and talk about whatever issue. So this is what we call academic honesty. Sincerely, she had mentioned that she put the perineal pad there, and then she forgot to remove it. And that is what we are seeing, that practically, if it is not suturing, but before you pick the pad and you want to insert it into the woman's vagina, for heaven's sake, please show it to the woman. Madam, pardon me. I'm coming to push it into your vagina because you have a tear, or I gave you an episiotomy. I'm coming to suture. So I'll push it halfway inside your vagina to prevent blood from occluding where I'm coming to suture. So when I finish, do remind me to remove it. Don't tell the woman, Mommy, we are kind, let me hear the name of I just say, shop at a bedroom. Let her know the rationale behind you, what you're saying. Let her know the reason why you are telling her. In fact, if you had mentioned this to her, she wouldn't have taken it home. There's no which you put, she will send a near part home. Take it, show it to her. Madam Share, Brunitan. That's how they call it, Brunitan. Pardon. May the best was sick. May the best man have a confusing ya. Dear Carabet, when you ever was sick. Me, we are kind, Madam. I didn't know the share must be. Then I'll remove it. But if you don't inform her, she's not aware before you could say Jack. Midwife, the midwife has picked the part. Oh, she's pushing it. Because involution of vagina has started taking place, patient is in pain. Then you are shouting at the patient. She doesn't have any idea what is being pushed in her vagina. So please, let's learn to introduce whatever we are doing to the patient's vagina. Let's try to inform her. Let's add her. Let the woman be informed because it's a special place. The vagina is a special place. And so you cannot be putting things into people's vagina just like that. So that is one thing that we should change as first-degree midwives. We should try to effect some changes so that people let it reflect, the change should reflect in our activities, whatever we are doing for the patient. The change should reflect there. But I like the way she explained that she pushed it there. But the aspect that I didn't like is like she wanted to be annoyed with the patient when she came back to the facility. You don't have to know, you should rather feel guilty. You should rather feel guilty and apologize to the patient. That is what we are lacking now. We don't want to apologize to our client when we do something wrong. You didn't do well. So you should have apologized to the patient. Oh, madam, I should have removed this thing for you. I forgot, and you're also afraid to remove it. Kafra, I'll put you on antibiotic and nothing will happen to you. I'll remove it for you. Then you remove it. But you were rather getting angry because you think you told the woman that she should remove it herself. Is she the one who put it there? She's not the one. You put it there and you should remove it. Please, let's try to do what is right and what is good for our clients. If you involve them in whatever procedure that you are doing, because of fear, she will remind you, she will tell you, Madam, I don't know how to share or if you wear you. Then you say, oh, sorry, Kafra, that one mean mama. That is academic honesty. I don't involve them. We do our own thing. We think we have to apart our hands, we have control over the patients, and so we can do anything that we like. Otherwise, one day when somebody will take you on. Especially when the teenage this thing will remain, sometimes it will remain them 3 days it is there. 1 week it is there. The woman grandmother is afraid. She doesn't want to put her hand inside her vagina. Until it becomes so severe that she starts with sepsis before they will rush her to the hospital. It is so expensive. So let's try to do the right thing. Any more questions? Thank you very much for sharing that experience.
Thank you to Hajia.
You're welcome, dear. Okay. Yes. Let's quickly examine the placenta. Please, this is the placenta. I've sent it to the newsroom. When you get there, remember to scoop the blood clots on the surface here. Scoop all the clot, add it to the blood, the blood loss in the receiver and measure it. When you finish, get hold of the cord, put the placenta on a flat surface. Then we try to check on the surface. Use dry cotton wool to clean the surface of the cut cord, the cord. I'm talking about the one attached to the placenta. You are checking for the presence of 3 vessels. There should be 1 big vein, 2 arteries. C, a missing lobe. If there's any missing vessel, If these 3 vessels are not there, but there's a missing vessel, it's an indication of what? It's an indication of what? Oh, hello, I'm asking a question. What does it indicate? What does it mean?
A renal failure.
A renal condition is either there's a missing kidney or the patient is having, the baby is having a renal condition. Some books are saying that there's a problem with the ear of the baby. But if you don't examine the surface of the cord, how do you know? Some people just deliver the placenta and then straight to the dustbin. Please, you are a degree midwife. Make a difference. Effect a change. Let your other counterparts who haven't done the first degree and other things, let them know that you are now a change midwife. Now, so that is the surface. Then you take the cord. You are checking for the amount of Patton's jelly that covers the blood vessel. You are checking for the presence of true knots. You are checking for the presence of true knots like this. Have you seen the true knots? You are checking for the presence of false knots that looks like this. Please, have you seen false knots? Have you seen the false knots? That is how it looks like this, like that. It is not a real knot, but it's a false knot. Depending on the number of false knots, it may affect the fetus. So we check for that. Then we check for the insertion of the cord. You check for the insertion of the cord. You know, we have the cord should be in the center of the, it should be in the center of the fetal surface. It can be at the lateral side. It can be what we call battledore insertion. It's just situated at the edge of the cord, of the placenta. You check for all these things. Then after that, get hold onto the cord like this, then lift the placenta up. Please, have you seen it? You lift the placenta up, and then the membranes will be hanging. The membranes will be hanging. So when it hangs and it is ragged, you can easily see that the membranes is ragged. Ragged membranes means there might be a torn membrane that is left in neutral. Sometimes you put your hand inside the hole, you open your fingers, and you can clearly see that the membrane is complete, or it is torn, or it is ragged. You can easily see it. Please, is that okay? Now, when you finish, you turn the cord, then please check for the surface of the placenta. Check for the radiation, check for the distribution of blood vessels. Check for the distribution of blood vessels. There are 2 types of blood vessel distribution on the placenta. There are 2 types of blood vessel distribution on the placenta, on the fetal surface. There's one type of distribution, we call it magistral distribution of blood vessels.
That's very, so this is how it is. She should be teaching like this. Okay. The network is not good.
So that you see that the magistral distribution, with the magistral distribution, please watch out. You will see 2 big blood vessels running from the insertion of the cord.
Hey, come.
Before
I thought listen, I've gone there for long. I don't know.
Why lucky? So I'm saying that with the magistral distribution of blood vessel, you will see 2 major vessels emerging from the insertion of the cord before the tiny blood vessels are distributed on the surface of the fetal part of the placenta. That is magistral distribution. The other one is called dispersed. dispersed distribution of blood vessels, you will see that as soon as this is a typical disperse, the one you see on this model of placenta, that is a typical disperse. As soon as the cord is inserted, the distribution of blood vessels will take place. That is what we call dispersed distribution. So please, we have two types of blood vessel distribution, magistral and dispersed, which I've explained to you. Now, after that, you also have to check for the, you have done the checking of the lobe at the maternal side. Then when you finish, you are done with the examination of the placenta. Dip it inside the bleach solution for safekeeping. I mean, for the one, whoever is going to empty the placenta bowl to be safe, decontaminate the placenta before it is disposed of, so that whoever is handling the placenta bowl will also be prevented from other blood-related conditions or diseases. Please, that is the examination of the placenta. Any question? Any
yes, ma'am.
Yes, ask me.
Please, ma, I didn't hear when you examine the surface of the cord. I heard that a
Please, if somebody heard him, can you repeat what he said? Because that was the first thing, if I heard him right. Okay. Go ahead. Stephen, what did you ask?
I'm asking, like, I didn't hear the surface of, you said when you look at the surface of the cord, you might see something to signify that there's a missing kidney or something. I didn't hear it well, please.
I said the surface of the cord, you have to check for the presence of one vein, two arteries. That is, the presence of 3 vessels. I said you should look for the presence of 3 vessels. The vessels are 1 vein and 2 arteries. And I said when there's a missing vessel, it indicates that the baby might be suffering from problem or renal agenesis. She's having problem with her kidneys. That's what I said. That's what I said. Okay. Any more question?
Yes, sister.
Yes.
Please, for the the magistral distribution, we said that there are 2 major blood vessels that emerge from the cord inside, and the tiny blood vessels, where are they?
Yes. I said with the magistral distribution, the tiny blood vessels are emerging from the 2 major or 2 main vessels before you see the distribution on the fetal surface. That's what I said. That's the magistral distribution. And then the dispersed distribution is a typical of this one. As soon as the cord is set, then the distribution of the cord will take place. That is the dispersed distribution of blood vessels. Have I answered your question? Let me quickly tell you the abnormalities of the placenta, and then we are done with the labor. The abnormalities of the, unless somebody has a question for me, other than that, let me go straight to the abnormalities.
I have a question.
Hajia. Yes.
Please, wait.
Go ahead. Oh. Go ahead, please. Okay. I think her line didn't help her. Her line didn't help her, so let me go on to the abnormalities of the placenta. We have many types of abnormalities in the placenta, and then we have diseases of the placenta.
Someone will just pick your 5 CD like that. Meanwhile, you walk and you are tired. It's tiring. Okay. No contact of mine. Good. That place is just your clinic.
People, mute yourself. You can't hear Hajia.
Okay. Okay, so I'm saying that abnormalities of the placenta, we have what we call placenta subciliata. The thing
the class, mute yourself.
iPhone, but please mute yourself.
Hajia.
I'll put it in the waiting room. Don't worry, you don't worry.
Hajia, they are disturbing.
I am sending them there. Who is disturbing? Mention the name for me.
Halidu. iPhone Halidu. Abigail Nyamia. Nyamia.
Okay. If they start again, I'll put them there. I'm talking about abnormalities of the placenta. There's the placenta we call placenta subciliata. The placenta subciliata is like this. You see placenta like this. But then there's a blood vessel leading, these blood vessels that you are seeing. One will be leading to an extra loop. So you see an extra loop. You see something like this. This how you see. In between, there's a membrane. There's a membrane. Blood vessel is running through this membrane to supply this extra loop. To supply this extra loop. And that is why we call it subcinguate lobe or placenta subciliata. Placenta subciliata. Please, I hope that is clear. Hello? Are we together? Okay.
Yes, yeah.
Okay, so that is placenta subciliata.
Again.
Yes,
please come again.
again.
Please pay attention. I haven't eaten today. I'm hungry. Placenta subciliata, I'm saying that it is a type of abnormal placenta where we have an extra lobe like this. And in between the lobe and the male placenta is a membrane. It's a membrane through which blood vessel passes.
Abigail Nyamia.
What is wrong with you people?
I'll put it in the waiting. You should go and make a mistake. Okay. So I'm saying that is placenta subciliata. And that explains why when you examine the placenta, you have to separate the amnion from the ovule. Separate the amnion from the ovule. You know, the amnion is plain, it's transparent. Whilst the ovule is opaque. So when you examine the placenta and you separate the two, if there's any blood vessel running through the amnion to supply the extra lobe, or running through the ovule to supply the extra lobe, you will see it. And then you realize that extra lobe is not there, but the blood vessel is running through the membrane. The blood vessel is running through the membrane. So then you have to look for that lobe. It tells you that it has retained in utero. So put the woman on a gometrine or massage the uterus to expel the fundus and then get rid of that extra lobe that has retained in utero. Other than that, patient will end up with secondary PPH. I hope that is clear. That is the danger. That is the danger associated with placenta subciliata in relation to midwifery. That is it. Now, another abnormality of the placenta we call placenta circumvallata. Placenta circumvallata is where the membranes surrounding the placenta, that is the membrane, the ovule, is folded backwards. Please watch out. Let me widen this thing so that you can see it. Yeah. Okay. So please watch out. See this thing as the membrane covering the placenta. Please haven't seen it. That is the ovule. But placenta circumvallata, In placenta
Please, I can't
circumvallata,
see.
you can
Robert,
see that.
put it down.
Let others who can see, so that later I will explain to you. You see that in placenta subcuvata, this is how it behaves. The membrane is folded backwards. The membrane column is folded backwards like a collar. It's reflecting backwards and it's attached to the uterine wall. What do you think can be the danger associated with this side of it? What is the danger? Please, anybody to answer. What is the implication? What do you think can happen to the placenta?
Retain placenta.
No, madam. No. The membrane, you know the membrane. No. Not retain.
So the membrane will be detached.
The membrane will do what?
Detached.
It will detach and cause what? And great. Who said it? Who said it? Not postpartum hemorrhage. Who said it?
Rebecca.
Good. That is right. Because the membranes are supposed to anchor. It's supposed to anchor into the uterine wall and hold the placenta in situ. But here is the case that because of our abnormality, the membrane is folded backwards. So the possibility that it can easily detach the placenta and patient will end up with a crucial placenta. So that is the placenta circumvallata. That is the placenta circumvallata. Any question? The next abnormality of the placenta is placenta velamentosa or velamentous placenta. Placenta velamentosa. With the placenta velamentosa, this is how it also looks like. This is the main placenta. This is the membrane. But then you get the cord. You get the cord. You get the cord. Look at the veil as the membrane. Oh, the cord will be situated in the membrane. Please, have you seen it? This is the cord. It is situated inside the membrane, like this. The cord is situated in the membrane. The main placenta body is there, but the cord is situated in the membrane. And the blood vessels are radiating through the velamentous placenta, through the membrane, before getting to the main placenta. So if this is the cord, that is the insection. Blood vessels are radiating from this cord to the main placenta. Please, I hope you are getting the picture. The cord is situated in the membranes. Blood vessels are running through the membrane to the main placenta. Please, do you understand? In that case, what do you think would be the danger associated with placenta velamentosa? What is the danger associated with velamentosa?
Khadija, stop sharing your screen.
Who is that person?
I think the cord
Sister, please, can you go over with the placenta velamentosa?
Okay. I think we're in common way. I'm saying that this is the placenta velamentosa. The cord of the velamentous placenta is situated in the membranes like this. And the blood vessels, we told you that we have two types of blood vessel distribution, if you remember just now. So blood vessels are radiating from this cord, passing to the main placenta. It's radiating to the main placenta to supply it. Okay. And I'm saying that what do you think will be the danger associated with the velamentous placenta? Yes.
Bleeding blood vessels rupture. The blood vessels rupture.
Okay.
It wouldn't bring about placenta previa, but there's the first person who said the placenta, the membrane, because the vessel is running through the membrane, it can rupture. The one who said it, it is true. And that is what we call the vasa previa. Have you heard of vasa previa? Vasa previa, meaning vessel in front. So that if this part of the membrane is covering the fetal parts, the fetus, the fetal head, you make an attempt to rupture the membranes, and then it may rupture through the blood vessel that is leading from the cord to the main placenta, and then there will be intrapartum hemorrhage. There will be antepartum hemorrhage. Patient will start to see severe bleeding when the membranes rupture, either spontaneously or artificially. And we call it vasa previa. Vasa previa. So one of the implications of placenta velementosa is vasa previa, where the blood vessel can be ruptured because it is running through the membranes. When you meet it in objectives, try to do justice to it. Pick the right answer. That is it. So that is placenta velementosa.
Can fetal distress also occur?
Yes, it can bring about fetal distress because of the vasa previa. It can bring about fetal distress. It can bring about intrapartum hemorrhage or antepartum hemorrhage. So if all these things that we are seeing, if you don't examine the placenta, how would you know? And this will inform you to pay attention to that baby. This will inform you to pay special attention to that baby. After examining the placenta, hey, this was placenta velementosa. Let me go and look at the baby and see what is happening to the baby. That is it. Another abnormality of the placenta is placenta bicatheter. Placenta bicatheter. In that case, you have the placenta. Hello? We have the main placenta this way. But then, if there are two smaller placentae, the placenta bicatheter, you have two smaller placentae. One here, one there, but then one cord. So that as the cord is getting closer to the placenta, it will then branch. The cord will divide. So you have one branching to one smaller placenta, then another branching to the other smaller placenta. So you get something like this. One going to each smaller placenta. That's a placenta bicatheter. And if this is the type of placenta that was supplying the fetus in utero, the baby needs to be observed keenly. The baby needs to be. So that's a placenta bicatheter. The supply wouldn't be that much. Two smaller placenta supplying the fetus is abnormality. Then the battle door insection of the cord. The battle door insection of the cord is also an abnormality of the placenta. Actually, it goes with abnormality of dissection of the cord. This is where you will see, please watch out. You will see the cord situated at the very edge of the placenta. What do you think will be the implication? What will be the danger? Yes, any idea? I want to see more hands because we are familiar with this one. Battle door insertion of the cord. What do you think will be the implication in labor? Oh, nobody is talking. Yes, I'm there.
Hajia, please, it's about Matthew Duncan's method of placenta separation.
Not really that. Not really that. What will cause it? Somebody has mentioned something.
He said retain placenta.
And that's during the delivery of the placenta.
Break because of where it is. It will break and then it will lead to retain placenta. The moment you make an attempt to deliver the placenta, you don't know that it is battle door insertion. So the pressure that is exerted, you are delivering the placenta only for you to break the cord is left in your hand. And the placenta, retained placenta, it has resulted. So that is the danger of battle door insertion of the cord. So that is it. Okay, so these are abnormalities of the placenta. Please, I'm going to show you the diseases of the placenta, so that if I ask you to differentiate between abnormalities of the placenta and disease placenta, you should be able to do that for me in your examination. Diseases of the placenta. Diseases of the placenta. We have what we call placenta membranosa. Placenta membranosa. It is a type of placenta where please pay attention, because we develop exams. Pay attention and listen. Those that are put in the waiting room, they should remain there. After labor exams, then they will call it. Hajia, you gave me F. Hajia, you gave me, I gave you. That's what you wanted, that's what you got. Because they're not paying attention. During the anatomy, you were 527. Now you are 489. Those who didn't join, they are the very people. They think labor is so cheap. If it is that cheap, why is it that people are being referred in labor? Pay attention, it's your future. Don't joke with it. Okay, so placenta membranosa. I'm saying that it is a diseased placenta. You know, this is a normal placenta. The center of this placenta is thick. Getting to the periphery, the edge, it is lighter. That is normal placenta. In the case of placenta membranosa, the thickness of the entire placenta is like the edge. It's like the edge of a normal placenta. I'm taking it again. I say in cases of placenta membranosa, the thickness of the entire placenta is like the edge of a normal placenta, like this one. That is membranosa. So, and it is light, it is small. So if this type of placenta is supplying blood to the fetus in utero, where lies the fate of that fetus? And if you are midwife and you don't examine the placenta, you are likely to kill this baby because you don't know the type of placenta that was supplying this fetus. You see the essence of examining the placenta now. I hope you are going to examine placenta. Are you going to examine placenta before disposing?
Yes, sister.
Yes, sister.
I like the response.
With your help, we do it.
Thank you very much. I like that. Thank you. So that is placenta membranosa. Good. That is the placenta membranosa. Now, another disease placenta is placenta fenestrata. Placenta fenestrata, fenestrate. The placenta fenestrata is a type of placenta that has a hole inside. So if this is the placenta, you will see a hole inside the placenta. It's a disease condition. It's a disease condition. And it can, remember, because blood vessels will have to run and then pass through this hole to supply the fetus. The fetus wouldn't get enough oxygen. And so after delivery, it is the duty of you and I to examine and observe closely that baby. That is after we have examined our placenta to see that it is a fenestrata placenta. And so this baby's life is at risk. Now, we have another disease of the placenta. We call it placenta infarcts. That's the commonest. Placenta infarcts, where you, after examining the placenta, you see that when you come to the maternal surface, look at the infarcts. Have you seen the white things there? Have you seen them? This is typical of placenta infarcts. And wherever the infarcts are, it's an indication that blood supply to that part was lacking. So examine the placenta. If you see a lot of infarcts, observe your baby closely. Because what we call hot death. So examine when you see this plenty, in fact, as we are seeing on this placenta, be alarmed and watch the baby closely before it passes on. That's placenta infarcts. Then we have edematous placenta. It's a disease condition. It's a diseased placenta. And it is normally delivered by diabetic mothers. The placenta is quite big. It's heavy. It's broad. And when you press on that type of placenta, water will be oozing out. Water will be oozing out. Water will be oozing out of the placenta. That is typical of edematous placenta. Still, the baby wouldn't look healthy. So all these things explain to you when the baby is born, and sometimes in the court, we want the mother to breastfeed. Baby is not breastfeeding. If I were you, I would go back and examine the placenta that was supplying that baby. It will give you enough information about the life of that baby. So that is the placenta, what do you call it? Edematous placenta. The last one is what we call syphilitic placenta. The last disease placenta is what we call syphilitic placenta. In the syphilitic placenta, you can see the placenta is not looking healthy. It looks a bit pale. Then you are suspecting syphilis. You are suspecting syphilis. Probably the mother might have even had what you call syphilitic chancre. There is a small wound at the vulva when you examine the vulva before you do the V. The mother was having this kind of Ramatum sharp. If you don't stop that, and I'll put you in the waiting. So the mother probably might be having small wound, a small spot of wound at the vulva. It's a sign of syphilis. And so when you deliver the baby and the placenta is looking unhealthy, then you should be suspicious. So what you do is you take just a sample of the placenta, examine it to the lab, examine it under the microscope, and you see a lot of spirochetes. That is the organism that causes the syphilis. Then your diagnosis is confirmed. So the baby must be referred to the pediatrician for proper investigation and treatment. The mother must also be treated for syphilis. This, I hope you are getting my point. So that's the diseases of the placenta. So with the diseases, we have edematous placenta, we have placenta membranosa, placenta fenestrata, placenta, syphilitic placenta, edematous placenta as mentioned. Then I think that is the diseases of the placenta.
Infants.
Infants, thank you, placenta infants. Then we have abnormalities of the placenta. We have subcentrata, circumvallata, velementosa,
bipartita.
Bipartita. Then we have sometimes there's tripartita. Then bacterial infection of the core. They are all abnormalities of the placenta. Ladies and gentlemen, this is where the curtains will bring it, the lectures will bring. So if you have any question for me, ask for clarity. If you have any question regarding all that I've said today, ask for clarity.
Hajia, the song.
The song. The song for what?
Is there a song for abnormalities?
Yes, there is. There is a song for this thing. So I want a feedback. A feedback from you. Somebody should mention one disease of the placenta and tell me its impact on the life of the baby. Just one. When I mention yes, Bukari, Dubik, Rafi, go ahead.
Hajia, please, I have a question and I'll answer your question too.
Okay.
Please, my question is that with the placenta veneralis or the hole inside a placenta, no?
That one is a fenestrata. The hole in the placenta is called placenta fenestrata. Answer your question. Hajia,
please, how would you differentiate it from a missing lobe?
Oh, the difference is that with penetrator, the hole is penetrating through the placenta, like you can see through. You pick the placenta, you want to see somebody standing in front of you. Through that hole, you can see the person. That is placenta penetrator. Okay? But with the missing lobe, it is not like that. You take it, I'm taking this lobe out. It is like this. The missing lobe is like this. You see, it's not piercing through to the posterior side of the placenta. No. So that is the difference.
Hajia, to answer your question to example of a disease placenta, influx. With that one, you will see visible calcifications on the maternal surface. And every portion that there is a calcification, that it implies that there was not enough blood supply there. Hence, blood supply, that is, which is the source of nutrients to the baby, would have been impeded depending on the quantum of the calcification. So you have to monitor baby to see how baby will cope with extrauterine life, since some form of nutrition was impeded in utero.
Good, excellent, that's good. Now, one abnormality of the placenta and its impacts on the life of the mother or the baby. Fauzia Tanko. Fauzia Tanko.
Hajia.
Oh, yes.
Placental insection of the cord. With that, the cord is inserted at the edge of the placenta. So blood supplies is impeded. So the baby don't get enough blood supply.
Okay.
So at best, we have to monitor the how do I put it? We have to monitor the respiration of the baby. Because since blood supply is not enough, it can be deprivation of oxygen to the baby.
Yes, very good. Now, somebody, I'm going to mention your name. Everybody should be on their legs. Describe placenta circumvallata and its effects on labor. Theophilia pansa. Theophilia pansa. Placenta socinciliata. Placenta velamentosa or placenta socinciliata, either socinciliata, circumvallata, or velamentosa. Pick one of them and describe it and its effect on labor. Theophilia pansa. Theophilia, we are waiting for you. You can't say you will answer this question. Pick one. I didn't pick for you. I said pick one of the three. Okay. She says she can't answer. Yvonne, Yvonne, pick either placenta socinciliata, velamentosa, or circumvallata and describe. Yvonne Jessiwa. Hey. Physiology. Physiology. What is the crowd? Yes, anybody, please pick one in the any of them that you think you can comfortably describe. Yes, Erica, will you share your one?
Please, placenta circumvallata. It's where the amnion and the colon are double back. the circumference of the placenta. This will cause antepartum hemorrhage because it will the placenta separates easily. They are detached. The placenta is detached easily. So it will cause antepartum hemorrhage.
Good. I think we all agree with her. Thank you very much. Hassanan Musa, yes. Hassanan Musa, go ahead.
Placenta succinurator. That is when the placenta comes with an extra loop. The loop can retain after delivery, causing PPH.
Thank you very much. Thank you very much. Yes.
As you see what?
Patients are not cheap.
Huh? As you can.
Placenta vellomentosa.
Okay, go ahead.
That is when the cord is inserted into the membranes. If little pressure can cause the cord to tear, and there'll be retained placenta.
Retained placenta. Thank you very much.
Hey, Kakai, Oba, run.
So it goes like this.
Hey, God.
Okay. So the song is like this. Abnormalities of the placenta. It's like this. Placenta. Please keep quiet. Those of you who know how to sing, just keep quiet. It was all formulated by Hajia, and I'll take the credit for myself. It goes like this. Placenta has many abnormalities. Placenta has many abnormalities. Placenta succinurator, placenta mypatita, placenta subcubalata, placenta vellomentosa, and maternal insertion of the cord. Once again, is it okay?
Yes, Hajia.
It's okay.
Placenta.
Okay. Placenta
has many abnormalities. Please let
Madam,
us
keep quiet. Keep quiet. Na yen try the name to us.
Placenta has many abnormalities. Placenta succinurator, placenta mypatita, placenta subcubalata, placenta vellomentosa, and maternal insertion of the cord. So these are the abnormalities of the cord. That is the song. Maybe the disease of the placenta, I'll think of it and compose another one. On this note, let me solicit
Hajia, thank you.
You are most welcome. You are most welcome. So please, I will urge you, those of you who haven't paid your school fees,